So thank you all for joining us for this webinar. And the title is Why Your Frozen Shoulder Isn't Getting Better and What Actually Works to Fix It. And my goal here, if you're a person suffering with frozen shoulder or have a friend or loved one that's suffering through frozen shoulder, is to give you some current ideas about how we treat this problem, to give you some ideas about treatment options, and maybe give you other things that really aren't on your radar right now. And to give you an algorithm that's worked for me over the last 2.5 decades to help people dealing with this horrible kind of systemic disease process. Um, I'm here with Dr. Larry Burke, who is the founder of the largest frozen shoulder group on Facebook. And that's where we first met. And we're going to talk a little bit more about Dr. Burke towards the end of my presentation. My background is that I am an orthopedic surgeon. I'm based in Dallas, Texas. I'm actually a shoulder surgeon at that. So frozen shoulder is something I've been forced to love over the last 26 years. These other initials, because Larry Hass, this is a fellow of the Arthroscopy Association of North America. It just means that I've spent 10 plus years and been fellowship trained in sports medicine as part of that organization. And then RMSK is a designation that relates to being registered in musculoskeletal sonography. So that's just another certification that we've taken time to become proficient at musculoskeletal ultrasound. My website is texasorthobiologics.com. And like I said, I'm in Dallas, Texas. So a couple little housekeeping things. There should be a question and answer section that you can click on and drop your questions into that section. And we're going to save probably 15 or 20 minutes to do some live question and answer answering of all the questions that you may have. So at any point, just go ahead and drop them into that little section and we will get to as many of them as we can. And this will be recorded so we can post the video in the Facebook group, and we can even post answers to questions that we don't get to in the Facebook group.
Yeah, we got 4 questions already, so great. All right.
Fantastic. Yeah. Let me get this going. Here we go. So in terms of a handout, if you want to have a handout of, I think there's 35 slides, give or take, the handout can be located from any web browser. Just type in buford.info/frozen here. Or if you have your phone out, you can use this QR code. It'll take you to the same website. And that'll just give you a PDF of each slide. And like I said, this will be recorded. So if you want to see the actual video recording, you can do that at a later date once we have it posted online. So what is the problem with frozen shoulder? Well, the problem really is that a lot of clinicians treat it only as local pathology, as an isolated shoulder problem. And a lot of clinicians treat it just as a chronic pain problem and take patients that come into their office with this complaint and send them off to a chronic pain management or through a chronic pain management treatment algorithm that really isn't comprehensive or effective for frozen shoulder. And the result is patients have inconsistent outcomes. They go through these horror stories where they're dysfunctional with their shoulder for 1 year, 2 years, even 3 years or longer. And that really isn't necessary. And so the focus of this talk is to give both the clinicians and the patients a challenge to do better, to find a better solution. The reality is this: adhesive capsulitis or frozen shoulder, it's truly a systemic immunometabolic disorder. It's not just a shoulder problem. It is a systemic disease process. The shoulder is really the victim in this story. The shoulder is not the agitator. When we talk about this, let me go back. So when we talk about this, there are several well-known now and well-characterized systemic causes of frozen shoulder. This is information we didn't really have 25 years ago when I was going through orthopedic residency. But we now know that there's a strong hormonal component, particularly with estrogen levels and thyroid function. We know that on the metabolic side that insulin resistance can play a pivotal role in how affected someone is by frozen shoulder. Chronic inflammation is a common final pathway for patients that have frozen shoulder or develop frozen shoulder. And even our vascular health, our endothelial function can have an impact on whether or not someone develops frozen shoulder or how long it lasts. And so one of the questions that's been asked for decades, and I think now we have a pretty good answer, is why women? Because back when I was in residency, that was the answer. When we had our board certification exam, it was who was the average patient that gets a frozen shoulder? And the gender was women. The age was 40 to 60. But that's where our information basically fell off a cliff. We didn't really know why. And now I think we have a much better understanding of why we see this condition in women more prevalent than in men. And it really comes down to several things. One of them, one of the most important ones, is estrogen dysregulation. And in general, we're going to go through this in a little more detail, but that leads to fibrosis signaling and changes the pathways for our soft tissues, and particularly for our collagen regulation. This is why decreased estrogen is important and why you see increases in frozen shoulder incidence in perimenopausal women. When estrogen levels go down, you get increased fibrosis. Fibrosis just means increased thickening, increased collagen deposition. And what happens is decreased estrogen leads to increase in a protein called transforming growth factor beta that's been well studied now. That increases fibroblast activation, and the fibroblast is the cell that makes collagen. And so, depending on where that cell is, that may be something you want it to do. Like if it's in your face and you're using PRP to stimulate the fibroblast in your face because you want it to make collagen and smooth out those wrinkles, but not necessarily if it's in your shoulder, because if you have fibroblasts in your shoulder and in your shoulder capsule that are making more collagen, it's going to make that shoulder stiff. And that's what a frozen shoulder really develops from. Decreased estrogen also increases inflammation. It impairs tissue healing. It impairs endothelial function through a mechanism where decreased estrogen leads to decreased nitric oxide, and nitric oxide is important for the health of our vascular system, of our arteries and veins. And then finally, as if all of that wasn't enough, decreased estrogen also plays a role in increasing pain sensitivity. So everyone that has a frozen shoulder that says this really hurts and I don't understand, I'm not doing anything. Part of the reason, if you're a perimenopausal woman, maybe your decreased estrogen levels, because now you're at risk for having increased pain sensitivity, not only just from the shoulder being stiff, but just at a central level in your brain. So things that would hurt far less if you had normal estrogen levels now hurt more. Let's talk a little bit about the metabolic pathway. And the first thing, maybe the most important thing to talk about, is insulin resistance. We're starting to learn more and more that insulin resistance can have an effect across many different health parameters in humans. It really is an early metabolic dysfunction. I have patients that come in all the time and say, the doctor tells me I have prediabetes. And that's where the conversation stops. You know, my levels are okay, my sugar is okay, but the doctor says I have prediabetes. And that's important if someone has a frozen shoulder because the person's blood sugar could still be normal. And it's normal because the pancreas is now working double shift overtime to produce more insulin because that person is becoming insulin resistant. So if the normal targets for insulin are not responding, the first response from our body is to make more insulin. And that's what happens. And so that can still be addressed before it becomes full-blown diabetes, but by the time it becomes full-blown diabetes, that happens because the pancreas has given up. The pancreas has been worked to the point that it can no longer produce insulin, and now the blood sugars really do start to rise and will be abnormal on testing. Age formation is really interesting. Age stands for advanced glycation end products. And one of the things to remember in an insulin resistance state is that even though the blood sugar may be normal, there are still abnormal peaks, spikes and valleys and spikes in the glucose levels. And so glucose will bind to proteins like collagen. And when it binds to collagen, which is basically just a cross-linking, meaning it'll take collagen proteins and link them together where they shouldn't be linked together, and that makes them stiff. And so it has a direct effect on the tissues that have a lot of collagen in them, and the joint capsule around the shoulder is one of them. When you combine that with a receptor-based response, and so that's where this RAGE comes in. RAGE stands for the receptor for these advanced glycation end products. Remember, this is just sugar binding to a protein. The RAGE receptor is in the cell wall. And so when that receptor gets hit by one of these age products, these glycosylated or glycated proteins, it actually stimulates that cell to upregulate all of the things that lead to fibrosis, to make it simple. And that's not good. So you already have these end products binding collagen, but now when they hit the cell wall, that actually upregulates things that we know create more fibrosis and create frozen shoulder. In addition to that, they increase inflammation. And so all of these things become a feedback loop that is only negative if you're developing a frozen shoulder. And so treating it at its root, where the insulin resistance is first diagnosed, is an important aspect to treating someone with the frozen shoulder. Now, what about the pain pathway? There's three things to talk about. There's HPA, and we'll get into what that means in a minute. There's HPA axis dysregulation, there's neuroinflammation, and there's central sensitization. And starting first with some words that I never thought I'd have to see again once I got out of orthopedic surgery residency, but hypothalamic pituitary adrenal axis dysregulation, HPA for short. Why is this important? HPA controls cortisol. It controls inflammatory regulation. It controls our energy balance. And so some of the things that lead to dysregulation are chronic stress, chronic inflammation, chronic pain, poor sleep, or metabolic dysfunction like we just talked about. Any of those things can lead to dysregulation of this cortisol axis. And when that happens in our bodies, we have increased inflammation, increased pain sensitivity. It actually has a feedback loop where we get worsening insulin resistance, worsening metabolic dysfunction, and increased fibrosis. And so these things tie in together. And this is why it's much more than just a shoulder problem. Our nervous system gets stuck in this stress loop where more dysfunction of the HPA axis leads to more metabolic dysfunction, leads to more HPA axis dysfunction. So diagnosing that and addressing that is critically important for patients that need that piece solved to get better. So I'm going to talk about frozen shoulder phases, and I've simplified it to 3 phases. Now remember, whether it's frozen shoulder, anything in humans is not just black and white. I think most of us that are clinicians would agree with that. And so you can have somebody in a particular phase, but they still have some other component. For example, somebody could be frozen in phase 2 but still have pain. But let's go through these in general and talk about what the distinguishing features are of these 3 primary phases. Phase 1 is the freezing phase, which usually lasts from 0 to 6 months. Again, these are averages. Everything's personalized once we have an actual patient to sit down and talk with and sort out. The primary hallmark of the freezing phase is inflammation. And in this phase, patients tend to complain more about pain as opposed to stiffness. And the primary treatment goal here is to decrease this inflammation before they get into phase 2. Phase 2 is when patients are frozen or developing a frozen shoulder. And most people, when they say that, they mean they've lost motion. And it usually lasts from 4 to 12 months. Its hallmark is this fibrosis, this increased collagen deposition, this decreased collagen clearance it's multifactorial, and it is the hallmark of phase 2. People have stiffness more than they complain of pain. And the main treatment here is to break up that fibrosis that's happened. Phase 3, the thawing phase, lasts typically from 6 to 24 months or longer. It's important to remember that not everyone gets all the way better. And I'm not happy until our patients are back with a normal shoulder and no complaints. And if we stay diligent in phase 3, and we'll talk about this, so if we stay diligent in phase 3, we can get most people there. But it's important not to just hit phase 3 and then go on cruise control. There's remodeling going on, meaning that joint capsule, instead of being 10 times thicker than normal, that fibrosis is going away and the joint capsule is returning to its normal thickness and normal elasticity, if you will. The hallmark of phase 3 is there's a gradual return to motion, which we can accelerate in phase 2 by doing some of the interventions that we're going to talk about later on. And our goal here ultimately in phase 3 is to restore normal function. If you add all of that up, it is an incredibly long time. If somebody's at the upper end of these ranges, 6 months plus 12 months, that's a year and a half plus another 2 years. That's 3.5 years somebody could be bothered by this if we just say this will take care of itself. And I've had conversations online with people who say this is a self-limited disease, everyone gets better. Not true. But they think that everyone gets better, I don't have to do anything. It's just a little bit of therapy and some steroid. And that's, I think, a horrible treatment plan for patients in 2026. We have to remember as clinicians, no matter what phase somebody shows up in our office at, we have to remember that there are systemic activators and systemic drivers that are active in every phase. And so regardless of when that first office visit is, you have to ask these questions about insulin resistance and decreased estrogen levels, thyroid function, the HPA axis, and endothelial dysfunction. And if that's not part of your clinical practice, then you need a good partner who you can refer these patients to make sure that is sorted out and being addressed for them. And so that's, in a nutshell, what we do wrong with treatment for patients that have frozen shoulders. And this is still something that it's getting better as knowledge gets out, but as the 60,000 people in Dr. Burke's Facebook group will attest to, it's not universal. And using steroids alone for their anti-inflammatory effect is not enough. Physical therapy alone is not enough. Ignoring these systemic factors completely is often a decision or an unconscious decision that will lead to patients not fully recovering from this process. And this is what works better, and that's what we're going to spend the second half of this talk on. It's something where we have to identify and correct the systemic drivers first. They don't have to be completely corrected before we start the rest of our treatment, but we have to at least start paying attention to them so that we're in the process of correcting them. And then after we've done that, whether it's part of our practice or a referral to a clinician who specializes in that, we then have to personalize our treatment to the clinical phase or phases that the patient presents in. And so let's talk a little bit about lab work. This is how we start to sort out the systemic drivers. We're looking at insulin resistance, we're looking for thyroid dysfunction, estrogen imbalance, and chronic low-grade inflammation. And this is how we identify it. With metabolic or insulin resistance, we often are looking for fasting glucose levels and insulin levels. Hemoglobin A1C is another test that we will often order, and we will often get a lipid panel. Again, trying to determine if this patient is potentially insulin resistant, are they pre-diabetic? Thyroid function can be tested with some standard panels. The two most common tests for inflammation would be C-reactive protein or CRP and the SED rate, which is abbreviated ESR. These are typically non-focal, meaning they don't say that your shoulder's inflamed. They say that you've got increased inflammation in your body. On the hormonal side, there's some well-known tests for estradiol, progesterone. For men, we need to look at total testosterone and free testosterone. On the vitamin and nutrient status testing, I think one of the tests I did years back, something like 40% of the people that I operated on in Dallas were vitamin D deficient. And with that result, guess what? We started supplementing everybody with vitamin D that was going to surgery. Probably should supplement everybody that actually walks through our door, or really that even walks through our building needs vitamin D supplementation. It's actually cheaper to supplement vitamin D than it is to test for it. And these are some of the ways that we can treat the systemic drivers. Again, it's a little bit outside my specialty as an orthopedic surgeon and regenerative medicine specialist, but I have to know about it because I need to ask patients what they're doing to address these things if I'm going to be the best doctor I can for them and get them better in the time frame that I want to get them better in. Insulin resistance is usually treated with nutritional changes, exercise. Metformin is a medication that's commonly used. GLP-1 agonists are now commonly used to help with weight loss and other things now. For thyroid dysfunction, We need to optimize thyroid function. So if someone's hypothyroid or hyperthyroid, both of those need to be addressed to get the thyroid function as optimized as possible. Low estrogen, critically important to know this. We have to do or have to potentially consider hormone replacement therapy. We have to potentially address progesterone balance levels. For chronic inflammation, we start to get into some things like sleep, weight loss, anti-inflammatory nutrition, things like omega-3s, turmeric, other supplements that may be anti-inflammatory. A vitamin D deficiency, like I mentioned, supplementation is relatively easy and cheap. For the HPA axis dysregulation, remember the cortisol pathway, poor sleep is poor sleep is a very common source of dysfunction when we're talking about inflammation and cortisol levels. So sleep is critically important. Anti-stress, there's many modalities. A lot of them are going to be in much more detail in Dr. Burke's book. There's circadian rhythm correction. And so these are all things that we do to try and normalize these axes and these functions so that we can get the best result. Okay, so let's just take that, set it aside. We've asked the proper questions. We've made sure that these are being addressed. And now we have to look at how do we personalize treatment for this person according to their clinical phase to get them better within 3 months. In phase one, remember, this is the phase that is tied to freezing, where there's more inflammation and pain than there is loss of motion. And so number one, we don't want to lose motion. So gentle sleeper stretches. If you're going to use physical therapy, you need to be specific in the prescription that it needs to be gentle. We want to avoid pain. Anything in physical therapy that is over aggressive in this phase has the potential to backfire, because if people are going home from physical therapy and they've done so much or been stressed so much that they're now in pain, that could actually lead them to getting into phase two, where they start to lose motion because they don't want to move that shoulder. So gentle stretches are okay. We don't want to push through pain in phase one with physical therapy, whether it's home-based or at a facility. Something that's near and dear to my practice, platelet-rich plasma, is perfect for phase one because PRP can be a very good anti-inflammatory. It's made from your own blood. There's no downside to it. The dose is critical though. All PRP is not the same. So part of my soapbox with PRP is to understand how much blood is being drawn and understand the dose that you're getting, because the results could be vastly different. It's an anti-inflammatory, and it also downregulates some of the inflammatory cytokines that are involved in this inflammatory phase. A lot of clinicians still use corticosteroids. It's relatively cheap. It's anti-inflammatory. Probably the biggest advantage, two biggest advantages it has over PRP are that it's fast acting and that it is usually covered by insurance. PRP is not covered in the United States anyway by any significant insurance companies. And so there's an investment that has to be made if somebody wants to take advantage of what I think is the best anti-inflammatory injectable treatment option. In terms of oral medications in this phase, we have indomethacin, which is the strongest anti-inflammatory that I use. It's a once-a-day pill. I don't keep anybody on it for longer than 30 days because it's that strong. And furthermore, if someone hasn't gotten better from their inflammatory phase within 30 days, then I probably need to reassess them at that point and decide what else we need to do to get them on the pathway to recover. Oral medications like NSAIDs can also be useful. Some clinicians use gabapentin or pregabalin for its neuropathic benefits if they believe that the patient needs that sort of medication for nerve-related pain. And so let's talk about phase two. Phase two, this is when we now have a patient that comes in the office and they've lost motion. So their motion's like this or like that. And they may still have pain. Remember, these phases can overlap. So they may still have pain, but this is what's happening underneath the hood. In a normal shoulder, the capsule is like this one black line. In fibrosis, it is literally 10 to 15 times thicker. So patients that are doing this, they're not faking it. They literally can't move their arm past right here. And we know that because when we put them under anesthesia, guess what? I can't move their arm past there either until we do the manipulation. And so what you'll see here on the left is how we make this diagnosis. It's actually not very complicated at all. Patients can do this at home on their own. This is also how we track our improvement over time. And so in this example, this happens to be one of my nurses, and she's just showing how she's in this position where she's laying on her side. This is called the lateral decubitus position. And this particular motion is called supine. So she's laying on her back, but she's actually on her side, but it's supine abducted external rotation and abducted internal rotation. And in most humans, that should be 90 degrees this way and 90 degrees that way. So if somebody comes in and they're only at 40 degrees, by definition, they don't have normal motion, especially if we look at the other side and it's 90-90. It should be symmetric. And so any loss of motion is important clinically. There's two main reasons why that happened. Number one is frozen shoulder. Number two may be something like arthritis, okay? But we're talking about passive motion. So I'm not asking her to raise her arm up, because if you've lost motion doing that, then you have to throw in some other potential issues like rotator cuff tear. But if someone's laying on their side, even with the world's biggest rotator cuff tear, they should be able to do 90-90 passively. And if they can't, it's because they've got this fibrotic capsule, or they could have advanced arthritis. And that's easy to sort out in the office just with an x-ray. So in phase 2, with this problem that is now a mechanical problem, we've now got something that is blocking motion. And this is where orthopedics actually does well, because we're not just treating pain. And so these are the three main interventions that I consider when somebody shows up in phase 2, or even in phase 3, which we'll talk about in a minute. If they're in the thawing phase and they've plateaued, then we often have to go back to one of these options to get them back on course to get back to full motion. So I'm going to go through these one at a time. And let's talk here about the hydrodilation. So this is an ultrasound image. There's a needle that's coming in from the back of the shoulder going into the joint right here. So this green dot is tracing the path of the needle. And as we're injecting, see this black area expand? So this is just an injection of salt water. And the joint capsule, see if I can go back and show it again. Sorry about that. We'll get it to go here. Yeah, the joint capsule expands as we inject salt water. And for the clinicians, the question is, how much do you inject? I inject until they make me stop. Ideally, I would actually tear the capsule. We want to break that fibrosis up. And so people will benefit. Whatever you can put in is great. If you can do a nerve block and use some other little tricks that we have in the office, you can get in enough fluid to significantly distend the capsule and significantly help someone's range of motion right away. And this can be repeated in the office, and it's very safe to do. Now let's talk about the second option that was on the initial slide, the manipulation under anesthesia. And so here we have a picture. Obviously this is in the operating room because you have to give the patient a little bit of anesthesia. She's not completely intubated like a surgery, but she does have what's called an LMA, or laryngeal mask, that is protecting her airway. And what I'm going to demonstrate first here is that she does not have good motion. And this is my point, that when you've got this kind of fibrosis, it's not because patients are malingering. It's not because people don't want to move their shoulder. It's literally that bad whether they're awake or asleep. So I'll click on it here, and I'm just showing here an external rotation. This is that supine abducted external rotation. She's only going about maybe 10 degrees here. And remember, it should be 90. Her arm should be all the way down here. And when we go in internal rotation, she's not going much farther. So now we're doing the manipulation. If you see videos online, and I've seen them too, where people are yanking on the shoulder and jerking it out of joint, that's horrible. That's malpractice. That's not the way we do manipulations. What we should see is something like this, where this whole thing is almost real time. It takes 2 minutes, maybe 3 minutes to do a proper manipulation. And this is a real live situation here. So that's what it takes. Now I want to show you at the end of that manipulation, this is where we're at. Remember where we started, 10 degrees? Now she's back to 90. And this is literally 5 minutes later. That 5 minutes has probably shaved 3 to 6 months off of her recovery. And look at internal rotation. This has gotten better too. And the reason why we do these tests with somebody on their side or flat on their back is because it eliminates the scapular thoracic motion. So your scapula back here, it can move, And you could have a very stiff shoulder, but still do this because your scapula is moving. So that would make it really hard to track progress and outcomes. But if you stop your scapula from moving, now anything I do is just the glenohumeral joint. And that's why it's a much better test than just it's called the Apley scratch test, putting your hand behind your back. But when you do that, your scapula is involved in that motion too. So it's a little bit more precise to have somebody laying on their side. And that's also why the sleeper stretches work better if you're laying on your side. One of the things that's come up a lot in Larry's group is how much is a cash pay manipulation? How much should it be? This is an example from a couple weeks ago. You can see the date here is March 11th this year. And this particular patient had to pay $1,100 for the facility. There's three bills: facility, anesthesia, and me as the surgeon. And when you add those all up, it's $2,600. $1,100 for the facility, anesthesia is $500, surgeon $1,000. Yeah, it's not cheap, but we're going to save you months to years off of your recovery by doing something like this. And I only recommend it when I'm really confident that we can help somebody, because by the time they've hit my office, it's already been a year, they've plateaued, and they've tried many other modalities and nothing's worked. And when I lay them on their side, their motion is like this. They can't move at all. And so those people, we don't delay. There's no reason to delay them getting better and decreasing their pain and increasing their motion. And doing this manipulation like that leads to a lot of happy people right away. Now, they don't keep all that motion, but our goal is after a manipulation, they get better within 3 months, get back to their full motion. And then finally, the surgical solution. So if it's surgery, it's got to involve steel. And here the steel comes in the way of a pair of scissors. And so those are scissors coming in. And I know most of you haven't seen a lot of surgery, but that capsule is super thick. The fact that we can even see the edge of the capsule means that it's way thicker than it should be. And I'm just cutting from here to here, and you can see we've created a gap. And that's exactly what we want to do with the manipulation. We've done hundreds of manipulations where we then put the scope inside, and it basically tears just like if we had used a pair of scissors. So whether you're doing a hydrodilation, manipulation, or an arthroscopic release, the end result should be the same. I want to give you a couple examples of a sleeper stretch. And here we'll show Tiffany. I'm going to fast forward a little bit, but notice that he's going to lay on his side. And again, the reason we do that, the reason you can't just do it sitting in a chair, is because you have to stop this scapula from moving. And not only is this how we diagnose frozen shoulder, this is how we treat it at home with these stretches. And this is also how we measure progress, because as soon as someone gets back to their normal range of motion, they're done. And so this stretch is something that you do at least twice a day, 2 sets of 20 repetitions in each direction. Some technical pearls. Notice that he's pushing below his wrist so he doesn't hurt his wrist or his hand. And he's just going to go to where he feels tightness and hold it for a 10 count. The whole goal here is to slowly stretch out the remaining tightness. And so we believe in these a lot because it's a tried and true way for people to get motion back on their own, to the point that I've had patients that can't really afford to go to physical therapy. And as long as they do this, 3 times a day, they get better. They get the same end result. And so let's talk a little bit about phase 3. So now we're into the thawing phase, and people are getting increased motion. And again, the caution here is don't throw the victory party yet. Don't slow down. We still need to be aggressive with our physical therapy. In fact, this is the phase, unlike phase 1, where in physical therapy, you can be more aggressive. You can actually push things a little bit more. There's less risk of turning this back into phase 2. And so whether it's sleeper stretches at home or working with a therapist at a facility or both, this is when you can be more aggressive. And now this is how we can also track our progress. Now this is just an Apple iPhone. There's an app called Measure on the phone. And this is just a nice slick way to measure motion. So you can see here she's at negative 18 degrees. And for her, normal should be 90. So she's got about 70 degrees to go in that direction. And in the internal rotation direction, she's at 40. And again, normal's 90 for her. So she's got 50 degrees to go. And here's how we use that information. If somebody does sleeper stretches at home and does it, two sets of 20 repetitions 3 times a day, they will improve between 5 and 10 degrees per week. So if she's missing 40 degrees of motion and she gets after those sleeper stretches aggressively, meaning she's going to get 10 degrees of improvement a week, that's 1 month, right? She's missing 40 degrees, she's going to get 10 degrees a week. So we should be able to get her better 1 month in 1 month. And she can track her own progress week by week. If somebody doesn't do it as aggressively and they only get 5 degrees of improvement, then it's going to be 2 months for them. And so there's a definite patient mediated component to this where you've got to do some of this work at home where we can't do that for you. In terms of putting this all together, and then we'll get to the questions, we always need to evaluate and address the systemic drivers of adhesive capsulitis. And so if you're a patient listening to this, again, if it's you or a family member or a friend, we need to ask, or you need to ask your clinician if they haven't. We need to look at my labs. I'm perimenopausal. We need to look at these labs, and here's some ideas. Or I need to look at my testosterone levels if I'm a man. Or I need to look at my metabolic function. I need to look and see if I might be insulin resistant or pre-diabetic, because all those things need to be addressed as part of the overall package to get someone back to health. In terms of history and physical exam, is there a history of surgery? For me, that matters because it may make it much more likely that I do an arthroscopic release with those scissors, because that's a lot safer than doing the manipulation if someone's had surgery. In terms of the manipulation, by the way, I've had 0 complications in 26 years. Now, I was taught by somebody who's world's best shoulder surgeon, one of the top 3, I think, of all time. And so I learned a way to do it that was safe and atraumatic, and anything can happen. But knock on wood, it hasn't happened over the last 1,000 or 1,500 or however many I've done. And if I was worried about safety, then we would go to the arthroscopic solution. But a manipulation is not something that anybody on this webinar should fear. In terms of decreased passive shoulder range of motion, so now we're here. Remember that if you have decreased range of motion passively, it's either arthritis or a frozen shoulder until proven otherwise. And then as a clinician, we need to look at other psychosocial factors. So as a patient, have you had a recent stress in your life? Has there been some other emotional trauma? These are things that need to be addressed and sorted out because they do play a component in the development and in perpetuating frozen shoulder. And some of these are beautifully addressed in Dr. Burke's book. So, and again, I'm going to give you the reference for that. In terms of imaging, imaging is not needed to diagnose a frozen shoulder. So I'm going to say that again. Imaging is not needed to diagnose a frozen shoulder. It is a clinical diagnosis. All you have to do to diagnose a frozen shoulder is put someone on their back and check their range of motion. And if it does not match the other side, it's a frozen shoulder or arthritis. And if you happen to have an x-ray, you can sort out which one it is between those two with a simple x-ray, an axillary lateral x-ray. So we get imaging though almost all the time. And so, I know you're all thinking, Donnie just said we don't need imaging to make the diagnosis. Why would you get imaging? And the reason is sometimes frozen shoulders happen because your body's trying to heal some other injury and the process just kind of goes off the rails. And so your body's trying to heal a small rotator cuff injury, for example, and they're, for whatever reason, maybe you're predisposed because of some insulin resistance. Now your body starts creating this collagen response that is over-aggressive. So we get the imaging to look and see if there's any of these other injuries that we need to be aware of, like a rotator cuff tear would be a good example, a slap lesion, which is a biceps tendon anchor tear inside the shoulder, maybe a loose body in the shoulder. So that's why we get imaging. It can confirm a frozen shoulder sometimes, but we're not, at least in my practice, I'm not getting imaging to look for frozen shoulder. In the freezing phase, remember our goal is to decrease inflammation and prevent loss of motion. We use medications and supplements. We use orthobiologics like PRP, which we inject into the joint. And we use other anti-inflammatory modalities, things like, you'll hear about DMSO and some other things in Larry's book, Dr. Burke's book. And then the sleeper stretches are usually something we can count on in any phase, honestly. In the frozen phase, this is when we can have the biggest impact on people's recovery time because they now have a mechanical problem. They have a capsule that is measurably abnormal and thicker. The manipulation under anesthesia is the most predictably effective option here for shortening recovery. There is nothing wrong with the hydrodilation in the office. Like I said, it's easy to do. You don't need to book time in a surgery center or in a procedure room. So I do a fair number of hydrodilations. And often, if that does the trick, then we never get to a manipulation under anesthesia. Even a second hydrodilation can be done before you go to a manipulation. But for the patient that comes in that's really locked in and really frozen, we will certainly have the manipulation under anesthesia as an option. And then again, the arthroscopic capsule release is kind of the ultimate option where we physically cut the capsule and watch that capsule release. So my goal is that with an approach that's focused on first on the systemic drivers and then using aggressive phase-specific therapies, we can, and even beyond we should shorten the time frame from 1.5 years or beyond to 3 months from the time that any patient hits my door. That is my goal. If I can't get someone back in 3 months, I'm not happy. And obviously they're not happy either, but that is our goal. And we meet that goal, a large percentage of the time, above 80% of the time. It's a study that we probably need to do, but we have a lot of testimonials and patients that will attest to that. Remember, though, that this is a partnership. I can do some of these things, and clinician can do some of these things, but you've got to take the medication. You've got to make some lifestyle changes if those are important on the systemic side. On the stretching side, you have to do those stretches on your own. So it's a partnership, and work is required by both of us. Now, this is the book that Dr. Burke has. It's up on Amazon. It lists many more treatment options and some fantastic ways to think about frozen shoulder that will help a lot of you in this journey to get better. The Facebook group, if you're not in the Facebook group and you're on this call, this has almost 61,000 members now. It's on Facebook. It's the Frozen Shoulder Healing Group, and it's a great place to exchange ideas, to look for support, to post questions. And it's been a tremendous resource for me just to see what people are struggling with and to see what the most common questions they have that need answering. And so thank you. You can find me on all these different social media platforms, usually under Dr. Don Buford. I'm on probably LinkedIn and YouTube the most. All of the videos you see in any of the talks that I give, including a lot of the talks, are actually on YouTube under my name. And if you want to see patients that have had frozen shoulder at various stages and had various treatment options, you can go to our website at Texas Orthobiologics, and you can hear it in their own words. So I thank you for your attention. I'm going to stop the sharing here. All right. Can you still hear me, Larry? Or was I talking to myself?
Yeah. Don,
Okay.
thanks so much. That was
Okay.
a tour de force half hour of frozen shoulder wisdom. So thanks so much for that. And
Yeah.
yeah,
So if you guys haven't seen Dr. Burke yet, he's here right there. You see him. I'm going to start going through some of the questions.
yeah.
And here's a question here, Dr. Burke. When you are going through the freezing state, should you do physio to try and maintain your range of motion or just allow the process to take place? If you do physio, should you still do exercises, stretches if they cause the deep cramping pain in your arm? How do you know the right amount to push yourself without making the situation worse? So that, why don't I take this first one, Larry, and I'll give you the next one.
Yeah,
So
definitely.
that's something I talked about in phase one, in the freezing phase. It is important to maintain your motion. And so gentle, but the key was gentle, remember? You don't want to come home from therapy or even finish a session at home where you're hurting. One of the guidelines I give people is you shouldn't be hurting the next day from a therapy session. Okay, not in this phase, maybe in phase three, but not in this phase. And so, and the reason is you don't want to create any rebound inflammation that would actually create this loop that would make things worse instead of better. So the answer is yes, I think you should still do physio. I think you should still stretch. A lot of insurance companies in this country only give people a certain number of physical therapy visits, which is grossly unfair in my opinion for the premiums they charge us. But you need to know that. If you only have 24 therapy visits, I'm not going to burn them in phase one for a patient because you can do sleeper stretches at home. And we may need those physio visits if we get to phase two. Okay. So if somebody's doing sleeper stretches at home and they're doing fine in phase one, we'll stick with that. If for some reason it looks like they're not getting better, that might be the time we start to incorporate formal physical therapy. So we got that one. Uh,
Yeah, Don, this is an important question about about repeating procedures in general.
Hmm.
Like how
Hmm.
many times should you repeat hydrotilation? How many times should you repeat steroids before you go to MUA?
Um, Man, it's such a great question. I will repeat a hydrodilation if the patient tells me they got measurable improvement. Okay, because there's no downside to it. It's low cost. It's in the office, and I'm happy to do that. Um, I think the manipulation is a more powerful treatment, but it comes with. Now, here's the thing, though. That cash pay cost isn't for everyone. Somebody could have insurance where an MUA costs them $300, or even zero if they've met their out of pocket, for the year. So we always make sure patients know not only their options, but also the relative costs of each option so they can make the best decision for themselves. But I will repeat a dilation as long as it's made a benefit. I don't like doing a lot of steroid injections in the joint. If there's any way to do PRP, I greatly prefer that because we've got data now showing that even the very first steroid shot starts a negative cascade for the cartilage, which isn't part of this frozen shoulder problem. So I hate doing a treatment that potentially will create a problem downstream. Um,
So you can
what?
do the PRP with the hydrodilation?
Absolutely, you can.
Okay. So
Yeah.
for Leslie's question here, then it's
Mhm.
been 2 weeks after having the first
Mhm.
one 7 weeks ago. That's nine. And how much time do you recommend in between these things?
Yeah, that's a great question too. So after a hydrodilation, you've got to give people at least a month to work on their stretching to see where they're going to end up. And at the end of that month, and that's another thing, patients with frozen shoulder, I'll see them monthly. We need to keep track of them. And if it's really bad frozen shoulder, I may even see them every couple weeks. But because I want to make sure that they're holding up their end and that I don't have something else that may potentially help them. But after a month, if they come back in after a hydrodilation at a month, and the visit goes something like, "That really helped, but I think I've plateaued. I've gone from 20 to 60 degrees, but I'm not really. This last week I haven't gained anything." And that's when we think, okay, well we've got the same. We can MUA, we can do another hydrodilation. What do you want to do?
It sounds like Leslie improved after the first one, so
Mhm.
probably worth having a second one.
Yep, and she's right at the right time interval that I would think that's a reasonable thing to do. It's about
A-
7 weeks.
And when people ask about repeat steroid shots, is there a recommended interval there?
Um, I I wouldn't do it any sooner than a month, but that's just my kind
Hmm.
of experience and thought. Um, Most people are going, well, not most. A lot of us in the regenerative medicine world are going to much lower doses of steroid than we were brought up or taught to do in medical school back in the late 90s. And so instead of doing like, 40 milligrams of a steroid like Depomedrol, we're putting in, a half or most of us actually even like maybe even a tenth of that and seeing the same benefit.
Wow.
So trying to minimize the steroid dose is important. And if we do that, then that would be a one situation where I would do multiple steroid shots. But again, I'm trying to have a month in between for the same reason. Um, let's look at okay, here's one from Mandy. Does hormone replacement therapy help with frozen shoulder in women going through menopause? 100%. Yeah. And so here, Mandy, remember that it's the decrease in estrogen that leads to the upregulation of inflammation, of fibrosis, of many other things that the final common pathway is fibroblasts are making more collagen, and that collagen is not normal collagen on top of it. So normalizing that as much as possible is actually a valuable thing to do for most perimenopausal women. Uh, let's see. I wanted someone to ask about. Um, okay, here's a question from Leslie. I would have Leslie just answer or ask me that offline. We can for sure get her sorted out. Um, Here's another one. I am 6 months in with a frozen shoulder. I feel I'm starting in thawing, but still have much pain some days. Other days are better. Is it too early to be thawing? Range of motion slightly better, but I can lift my arm but I don't know if that means I can't lift my arm much at all.
Yeah.
So, so remember we said these phases are nice. And especially, there's mostly orthopedics is and if you look at the history of frozen shoulder and who described it, and it was orthopedic surgeons, and we like very simple ABC, small, medium, large. There's no orthopedic classifications that are like 15 long. Actually, that's not true, but there's not many of them, and none of us like it. Um, and so we have these phases for frozen shoulder, but that doesn't mean that every person automatically fits one phase. And so you can have pain and be thawing. You can have pain and be frozen. Um, you can be in the inflammatory phase, and there's shades of gray, right? As you start to get more frozen, you may start to have more pain. So the answer to your question, you could be in the thawing phase and still be having pain, but the key is um, it's hard to it's hard to miss a little bit of the frozen phase. Okay, and you've already hinted at that because you say your range of motion is slightly better, but you can't lift your arm much at all. So given that everything else is already in the works as far as being sorted out, like there's no other injuries and some of the systemic issues are being addressed, then then I would say we go after the main culprit right now clinically, which is your lack of motion. Okay, so that would put you, for me, in terms of treating a patient with this kind of presentation, we want to get you to where you can move your arm. And we've got hydrodilation, MUA, arthroscopic capsular release. And, usually it's hydrodilation and MUA because, again, the ACR is not done very often. Um, I don't think it's too early to be thawing, I guess is the ultimate answer to your question. But I do think range of motion is where you need to spend a lot of your time right now.
And Don, I was going to speak to
Yeah.
that HRT question again too, because I appreciate you advocating for women to get on HRT,
Hmm.
because a lot of people have been scared about that due to side effects in the past, but,
Hmm.
but I think it's clear that the benefits exceed the risks.
Hmm.
Now, unfortunately, if they're going to their doctor and saying, "What does the literature say?" My Duke colleagues showed that if you're on HRT already, you have half as much chance of getting a frozen shoulder. So that's a preventative.
Hmm.
Uh, Unfortunately, there hasn't been a single paper yet showing that going on HRT will improve your frozen shoulder. Although we have people in the group saying it did help.
Hmm.
Of course,
Yeah.
we got other people say I've been on HRT for years and I still got two frozen shoulders. So,
Right. 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 Yeah. I mean, humans are weird, right? Anything can happen.
but there's no downside to going on it, so you might as
Right.
well. Yeah, yeah, yeah.
And that's the key. That's the key. Um, Here's a question. How would one manage someone who had chronic rotator cuff tear and frozen shoulder for a 75-year-old woman? So, so I guess the key in that question is a chronic rotator cuff tear. So someone has not had surgery. It's not a rotator cuff repair. If someone has a chronic tear, um, then we basically would politely ignore it if that's been the treatment decision.
Mhm.
Um, one of the first conversations Larry and I had a couple months ago was regarding kind of what do I treat first when people have multiple injuries. Frozen shoulder is always the number one thing you have to get better. So if I knew, like, let's just say with this question that somebody came in and they had a newly diagnosed rotator cuff tear and a frozen shoulder, I don't just go to surgery. We have to get the frozen shoulder better because surgical results are horrible if you don't have the frozen shoulder addressed. It doesn't have to be 100%. I mean, you can get by if someone's got 70 degrees because you can do a little manipulation at the time of surgery and um, and safely do the surgery. But if somebody is deep into the frozen phase and you operate on that shoulder, which is going to require them being still for anywhere from 2 to 6 weeks, you've just taken them from frozen phase to locked in concrete. And it is really hard to get their motion back. And whatever you tried to fix has a lower chance to heal too. So that's a little bit different if the tear is chronic, though. If the tear is chronic, then we weren't going to, the decision's already been made that we're not repairing that. And if that's been the decision, which sometimes happens, then we treat the frozen shoulder and see how someone does clinically. If you treat the frozen shoulder and their motion comes back, even with a tear, because people with tears can still have shoulder motion, then that's the end result that we're shooting for anyway.
Yeah, I think having read lots of MRI scans of rotator cuff tears,
Hmm.
people need to be aware. You can have small cuff tears and they might be clinically insignificant. You can have large cuff tears that have a lot of muscle atrophy. And in that case, the horse is out of the barn and you can't repair it. So, yeah.
Yeah. The Here's a quick question about vitamin D. Do I have a recommendation for how much vitamin D to supplement? If you're in a situation where you're getting labs tested, it's pretty easy for them to throw a vitamin D onto that. But I wasn't joking when I said it's actually cheaper to supplement than it is to test. I don't think, basically, if you go to a CVS, I don't want to use brand names, but if you go to a pharmacy and buy vitamin D supplement and just take that as directed on the bottle, that will do the trick usually within a relatively short amount of time, unless you're very, very deficient. If you're having other symptoms, whether chronic disease symptoms or what have you, then I think it's worth getting the test. If you're just getting started in this frozen shoulder diagnosis, it's part of the workup to evaluate some of these systemic causes.
And also depends what the season of the year you're in, because
Mm-hmm.
I quit taking my vitamin D supplements during the summer when I'm out getting as much sun as I can.
Mm-hmm.
And during the winter, I take 5,000 international units a day,
Mm-hmm.
which and you also recommend taking with vitamin K2 to
Mm-hmm.
balance it out. So,
Yeah.
but people who are really deficient, they're going to take 10,000, 20,000,
Mm-hmm.
until they get up. I mean, if you're at like 10 or something like that, that's ridiculously low. You want to be up to 50 as quick as possible. So, yeah.
Yeah, that's exactly right. And I guess what we found was, even in Dallas, people don't get out as much as they used to. Luckily, in city planning, they've started to realize that. So they're planning for open spaces. Like there's, parks in Dallas that weren't here 20 years ago, where people can get outside. But that's important. That's definitely important to get your natural vitamin D too. Um, Here's a question from Miss Cynthia. Could I have caused my frozen shoulder by starting HRT and then stopping it? I
Mm,
restarted HRT after the diagnosis of frozen shoulder, but I'm
mm.
already in a lot of pain and loss of range of motion. So I'll let you take that. I like you gave some good information on it already. Yeah.
Yeah, I mean, it sounds like you might have pushed yourself into an inflammatory state by
Hmm.
stopping the HRT. Getting back on it, again, it can't hurt, but you might have to do all the other things Don's recommending.
Yeah.
Yeah.
Let's see. No, I know it's 1 minute after 8, but we started 5 minutes late, so I think we'll go to 8:05 and then we'll give you your evening back. I appreciate everyone taking the time here. And if it's useful, we can do this every quarter, 6 months, whatever works for you guys. Um, let's see. Okay, we did that.
And Mandy, when you're asking about estrogen progesterone replacement therapy, you need to consult your gynecologist for that, or
Yeah.
your internist, yeah,
Yeah, that's one where you don't want your orthopedic surgeon
or your
unless
radiologist.
or your radiologist. Good point. You know, and there's the beginnings of a joke in there somewhere. You don't want us doing that. Um, let's see. Okay, can you please show how far a person in the frozen state can move their arm up and out to the side?
Mm,
No, okay, so that's a good question. So here's the thing, Mandy. Anything less than normal for me is frozen. So let's just say that this is my normal side, and I can do this, and I can come out and abduct and do this, and I can get behind my back. And on this shoulder, let me turn from the side. Let's just say on this shoulder, I can get all the way up to here, and I'm stiff because this is my throwing arm, and I've just got decades of abuse on this shoulder. But let's just say on my other shoulder, I'm coming in to see myself, and I say I can only get to here. I haven't lost a lot of motion, but it's not here. It's not the same. So that by definition is frozen to me. Okay. Especially if that's the reason I'm coming in. Now, if I'm coming in because my knee hurts and this isn't even a problem because it doesn't hurt, then all bets are off. But that simple decrease in motion meets the definition of frozen shoulder. And then the next little bit of the puzzle I need is this arthritis or is this truly capsular thickening? and an X-ray solves that. Okay, and then any other imaging is really to see any associated problems, whether it's ultrasound, MRI scan, or whatever else we get. So you literally could be up to here and still have the beginnings of a frozen shoulder. Some people come in and they're really locked in, Mandy, and they can only get to here. And then it becomes pretty obvious. Now, if they're just sitting on my couch in the exam room and they're doing this, I still don't know if this is because they have a huge cuff tear or a frozen shoulder or something else that's limiting their motion. But I lay them on their side, and now on their side, if on their side they go back and they can do full motion, it was because they probably had a cuff tear, and imaging is going to show that. But if they come in like this and I lay them on their side and they still can only do that, it's frozen shoulder. Again, or arthritis, but likely a frozen shoulder because she's a 50-year-old woman and has no history of arthritis, and the story matches a frozen shoulder. So there's a big range. There's a range from zero, literally from 0 to 90 degrees to all the way close to normal that could meet the definition of a frozen shoulder. Um, Now, I read the rest of your message here. The key, the best thing you can do at home right now is probably the sleeper stretch. In terms of working on your motion and maintaining your motion. And you know, it's hard for me to give direct advice, and I'm not supposed to, according to multiple legal recommendations from various organizations. But in general, if someone came in with that situation, we would go after the easiest things first to correct, which would be doing a rigorous home stretching program, which again, there's other stretches besides sleeper stretch. Just in my experience, that's been by far the most effective. Um, if somebody can't move their shoulder at all, then yeah, you need to find someone that can probably, you know, if someone is locked in like this, that's the person that goes straight to an MUA for me. Because I can take them from here to here in 5 minutes. In fact, that woman in the video, that's where she was. Okay. Remember, she was like 15 and 15, which equates to this. And I can get them all the way back here. And what happens that same day of the manipulation, even though I had her back here in the operating room, she'll be above shoulder level. She'll be about here. And on balance, people after an MUA are somewhere in here, and they get from here to here over the next 1 to 2 months. That's our goal. That is the sum cheat sheet to how we get people better in about 3 months. If they need an MUA, we don't dilly-dally. And if they don't, because they're close enough that we think they can get there without it, we do a hydrodilation and make sure they're aggressive in their physical therapy, whether it's home or at a facility.
I
So
think that's a good note to end on, Don.
yeah,
Yes.
let's do it. Okay. Thank you all very much. We'll save some of these questions and address them in the Facebook group as well.
And we're gonna put the recording will be available on the Facebook group, or we're gonna
It
do it.
will. I'll put it on the Facebook group and we'll put it on my YouTube channel as well. So there'll be multiple
Excellent.
places to find it. So I appreciate it. Thanks for the opportunity, Dr. Burr.
Hey, this is great. Thank you, Don.
Okay. Bye-bye.